It's a pleasure to address this workshop of medical students and others in Turkey. When I visited Turkey during my time as president of the World Medical Association, we had a very good meeting with the Turkish Medical Association. And also I gave a lecture at the university, and there was a lot of enthusiasm from medical students, which was very encouraging. And I think the enthusiasm relates to the fact that people everywhere are now acknowledging that there are huge and in many cases growing inequalities in health. I particularly emphasized inequalities by some measure of socioeconomic position. In country after country, we see a social gradient in health, illness, and life expectancy. So whether we classify people by education or some measure of deprivation, the lower people are in the social hierarchy, the higher the risk of illness, of death, and the shorter the length of life. And that's a remarkably general finding. We should also emphasize that in addition to socioeconomic differences, there are gender differences, and these intersect. There are differences by ethnic and cultural group. And we see, and I should imagine this will hit home in Turkey, that where there is discrimination against groups on the basis of their culture or religion or place of residence, that will often intersect with discrimination based on social and economic circumstances. So we see these intersecting causes of health inequalities, and we see them everywhere. And as I said at the beginning, in many cases, we see them growing. In my own country, in the UK, recent evidence suggested that health inequalities, the gap between the worst off and the average, did narrow when we had a government committed to reducing them. And when we didn't have a government committed to reducing them, they widened again. And in fact, recently I reported in the UK that the steady increase in life expectancy that we'd come to expect had slowed down. And that could in part relate to increases in inequalities. Major issue. In my WHO Commission report, the Commission on Social Determinants of Health, which we published 9 years ago now, we said that this was not in any sense a natural phenomenon. We said it's not simply due to lack of access to health care, but it's related to the conditions in which people are born, grow, live, work, and age, and to inequities in power, money, and resources that give rise to these inequalities in the conditions of daily life. That's what we mean by the social determinants of health, the conditions of daily life and the drivers of those conditions that act at societal level and indeed at transnational level. That's what the analysis showed, and we made a whole series of recommendations. And I'm very pleased that several countries have taken them up and are trying to implement them at one way or another. I was told, for example, that in Sweden, there are something like 10 Marmot reviews going on in different parts of Sweden. So they've taken the general approach that I've laid out, and then they're asking at a regional or perhaps a city level what they can do to act on the social determinants of health to promote health equity and reduce avoidable health inequalities. In Brazil, in Chile, in Costa Rica, in Slovenia, in many countries, they've taken this on board and are trying to implement it. Now, medical students might be asking, well, okay, but what's that got to do with us? If you're correct in saying that inequalities in health relate to the conditions in which people are born, grow, live, work, and age, and to inequities in power, money, and resources, well, we as medical students and former future doctors don't necessarily have the power to address those conditions of daily life or the inequities in power, money, and resources. During my time as president of the World Medical Association, I engaged with national medical associations, and I said my mission was to get doctors and national medical associations actively interested and engaged and active on social determinants of health to promote health equity. And we laid out 5 areas in which doctors, individual doctors, national medical associations, and other health professionals could be active. The first was education and training. Your medical students, you can ask yourself the question, how much of your teaching has been about the social determinants of health? And how much should be involved in postgraduate training? I mean, for example, when I was pushing this agenda in the UK, I talked to the medical royal colleges that are responsible for postgraduate education. The Royal College of Physicians now has teaching modules for trainee specialists in internal medicine on social determinants of health. The Royal College of General Practitioners, the Royal College of Psychiatrists, the Royal College of Obstetricians and Gynecologists. They feel it's vital to teach their trainee specialists about social determinants of health. In fact, the Royal College of Obstetricians and Gynecologists said to me that we think we should be the advocate for women's health through the life course. Wow, that's impressive. So education and training is important, undergraduate, postgraduate, continuing education. The second was seeing the patient in a broader perspective. And that's really part of being a good clinician. If a homeless person comes to you to be treated, you should ask, do they have somewhere to live? Am I going to treat this person and send them back onto the street? Now, you may say that you as a doctor can't solve the problem of homelessness, but you certainly need to see the patient in a broad perspective, and I'll come back to that in a moment. The third area, the health service as employer, looking at the conditions of work for doctors, nurses, laboratory technicians, drivers, cleaners, clerical staff, and the like. If the health service makes up, let's say, somewhere between 6% and 10% of gross domestic product, it's a major employer. That's a lot of people. So the conditions of work for doctors and nurses, very important. And again, it's close to home in Turkey. Doctors getting into trouble for treating patients, which is makes life difficult, stressful, potentially damages the clinician's health. So the health service as employer. The fourth area is working in partnership. Pediatricians understand this very well, and geriatricians understand this very well. As a pediatrician, you know you need to be working in partnership, not just with the family, but with other services. that support young children. They may be social services, preschool education, and the like. And at the other end of life, for older people, supporting them in independent living, dealing with questions of housing, financial support, social care. So it comes naturally to pediatricians and to geriatricians, but it should be true of all doctors working in partnership. And I said I'd come back to the homelessness question as an example, and that an individual doctor can't solve the problem of homelessness, but she or he can work in partnership with people who can address those problems. And the fifth is advocacy. In my book, The Health Gap, which I encourage all your medical students to read. Next time I come to Istanbul, I can sign copies. But in my book, The Health Gap, I quote Rudolf Virchow, the great German pathologist of the 19th century, saying that physicians are the natural attorneys of the poor. We, as health and medical professionals, should be active in advocating for a fairer distribution of the resources and the conditions that promote healthy lives for our patients and the populations that we serve. So there's much that doctors and other health professionals can do. I've engaged with the International Council of Nurses, trying to get them involved in this area. And certainly they're sympathetic. So doctors, nurses, other health professionals, when we pushed this in the UK, we got commitments from 19 separate professional groups of health workers. The physiotherapists, the occupational therapists, the midwives, the nurses, and so on. And underlying all of this is a commitment to social justice. If you ask yourself and your medical student colleagues, why did you choose to go into medicine? Well, there could be a number of reasons, but among them is almost certainly that you wanted to help people. You wanted, if people are sick, you had a mission to help cure the sick. I would argue, from a public health perspective, that mission should extend to helping societies become healthier as well as individuals become healthier. And if individuals are getting sick through no fault of their own, and that is potentially remediable, that's unjust, unfair. So as health professionals, we are working in the service of social justice. And that's got to be an important part of what animates us. And then we need to be informed by the best evidence. So I encourage you and all your colleagues to embrace this area. It's part of what being a good health professional means. And I look forward to further interaction as you progress. Thank you.